and I'm going to introduce two people who will introduce the Chakravarti lecturer. And our two introducers are, we are very proud to be able to include some of our students and residents as part of our alumni organization, let's say. So we have a student who's just entering third year medicine now in our new program, our 2+2 program, Galilee Thompson, and she's actually the incoming president. She's the vice president, I guess, of the Student Medical Society now, but she's also had, from the very beginning of her first year, significant interest in wellness, and she's completed even some research locally, I believe, in the wellness of students. And our second introducer, who will speak about our lecturer, is Jonathan Dean. He's an internal medicine resident now in his PGY 2 year, and he's the incoming president of the, will be the president of the PAIRS, which is the Professional Association of Interns and Residents of Saskatchewan, and he also has connections in this regard with a national body of residents, I believe, that's interested in wellness. So I'll let them both come up and introduce the lecture.
Good morning. I can't imagine a more fitting choice than Dr. Anita Chakravarti to honor for a wellness lecture series, and Dr. Dean and I are excited to play a small role this year by introducing the lecture. Dr. Chakravarti sends her regrets. She was unable to attend this morning as she was invited to speak on physician resilience and mindfulness at another conference. Dr. Chakravarti is an anesthesiologist by trade and advocate by choice. Originally inspired by her own challenging journey with chronic pain, Dr. Chakravarti deeply understands the importance of healing the healers, not only for our own well-being, but for the best quality patient care. In her words, this lecture was established to educate, inform, empower, and transform the way that healthcare is practiced in the 21st century. Dr. Chakravarti graduated from medical school in Saskatchewan in 1982 and completed her residency in Alberta. She later completed extra training in mindfulness meditation, acupuncture, and other evidence-based complementary and alternative medical therapies. She is founder and CEO of Empower Mindful Professional Practice, but continues to share her energy with many other initiatives across the country and internationally. Close to home, her roles as a consultant and mentor continue to drive improvements in well-being for medical learners and professionals. This lecture is intended to increase awareness of the challenges in maintaining balance in personal wellness and a career in medicine, in the spirit of the work Dr. Chakravarti is so passionately engaged in. Dr. Chakravarti is an exemplary role model. She truly lives mindfully, acts compassionately, and fosters togetherness.
It's our honor and privilege this morning to introduce the presenter of the second Dr. Anita Chakravarti Annual Physician Wellness Lecture, Dr. Peter Butt. Dr. Button is Associate Professor of the Department of Family Medicine at the University of Saskatchewan and previously served as Director of the Division of Northern Medical Services. He exemplifies a passion for physician wellness on both the provincial and national stages as the Physician Chair of the Saskatchewan Medical Association's Physician Health Program. In the words of Dr. Anita Chakravarti, and I quote, Dr. Peter Butt embodies physician wellness in his personal life and professional capacity. He is consistently kind, collegial, and respectful, fair and just in his interactions with patients and peers, as well as the students, residents, colleagues, and physician family members he assists in his role as the Physician Chair of the Saskatchewan Medical Association's Physician Health Program. Dr. Butt's presentation this morning examines substance abuse in the physician community. In the field of substance abuse, Dr. Butt has both clinical experience working with individuals with addictions and the expertise in development of community-based interventions and integrated treatment plans. Locally, Dr. Butt has worked with the Mental Health and Addiction Services and works to educate medical learners and professionals about substance abuse, detox, and therapy. Nationally, Dr. Butt is the College of Family Physicians of Canada's representative to the Canadian Centre on Substance Abuse, where he sits on the National Alcohol Strategy, National Treatment Strategy, Screening, Brief, Intervention and Referral Panel, and the Low Risk Drinking Guidelines Advisory Panel. So without further ado, please welcome Dr. Peter Butt.
Well, thank you very much for that very kind introduction. I don't really recognize that guy at all, quite frankly. My apologies for being late this morning, and my profound thanks to James for stepping up. It's greatly appreciated. So what I want to do is discuss with you this morning some of the fundamentals of substance use disorders. So we're approaching it from the neuroscience that currently drives how we treat addiction, and review the management of substance use disorders within the context of the Saskatchewan Physician Health Program, which has changed profoundly over the years, and I'll comment on that. And finally, explore the efficacy of treatment and the implications for improving care as we translate what we know from working with physicians to the general population, where this is not well managed at all, quite frankly. So let's talk about JH to begin with, a 38-year-old female surgeon who self-referred to the Physician Health Program for concerns over her drinking. This, of course, is not a true individual, but simply a representation. She had recently been apprehended for a DUI and had had her driver's license suspended. Colleagues had been increasingly concerned with late starts in the OR, poor record keeping, a general disengagement from her previous very active involvement in her practice. And her spouse had also expressed concern over her substance use, her alcohol use, but she had deflected any comments or attempts at having a conversation with regards to this. There were no informal complaints from patients or within the context of the hospital, the Regional Health Authority. Her current use was reported as up to 26 ounces of vodka each evening, and she would also have wine with her supper. Onset of use was at the age of 15, typically at weekend parties, which is a fairly typical adolescent pattern of use. She rapidly developed tolerance, however, and would drink 6 to 12 standard drinks per event when she was drinking. Binge drinking persisted throughout high school and university, with daily drinking evolving during her residency, albeit at a somewhat low level, but obviously increasing over time. She reported the occasional blackouts, but no DTs or seizures. Her spouse initially enjoyed the camaraderie at the parties, but became increasingly concerned with its escalation, her diminished engagement at home and work, and a depressed mood. Her two children increasingly avoided her and complained about her absences from school and other activities, and her irritability. Her spouse picked her up at the police station following the DUI and insisted on her engagement in care. So certainly some leverage was being applied there. Not an uncommon scenario, and unfortunately. So what is it that we're dealing with when we're talking about an alcohol use disorder or a substance use disorder? When we go to the Canadian and American Societies of Addiction Medicine, we have an interesting definition here as a primary chronic disease of brain reward, motivation, memory, and related circuitry. So right away, we're seeing something that's brain-based, but is also recognized as a chronic disease, which has implications in terms of intervention and treatment. We also see this as brain-based in the realm of motivation, memory, and reward, which of course is going to manifest itself not like a hemiplegia or a paraplegia, but rather in behavioral patterns. Dysfunction in those circuits leads to characteristic biological, psychological, social, and spiritual manifestations. Now, you may think that this is a bit peculiar, that a medical society would be projecting spiritual manifestations into a definition of a disease. But when you look at the pattern of behavior, typically what you see are individuals, particularly at a severe level, that are divorced from life. the activity that they're engaged in terms of substance use, or perhaps process addictions such as internet porn or gambling and so on, has completely removed them from the things that bind us to life, the relationships that we have, the work that we do, and so on. So meaning and purpose has shifted considerably. And this is typically what's meant by the spiritual manifestations. So it's reflected in an individual pathologically pursuing reward. And the paradox that we get engaged in working in this area is quite fascinating. The pathological pursuit of reward, in this case, with regards to substance use and other behaviors. Characteristics, fairly well defined, inability to completely abstain. So a person may be able to abstain for a good portion of the month, a check comes in, they're off and running and they spiral. So the consistency in terms of abstinence is lacking, impaired behavioral control, particularly in the relationship with the substance, craving, which can be quite overwhelming and difficult for most people to understand, diminished recognition of problems with one's behavior and relationships, the denial and so on, which is pathognomonic of the condition, which drives family, colleagues, and others quite crazy because it just seems so irrational. And of course, the dysfunctional emotional response, which is what we frequently come up against as clinicians in the emergency department or elsewhere when we're trying to address this topic, and typically get rebuffed very aggressively, very assertively, with a great deal of anger. But like other chronic diseases, there are cycles of relapse and remission to be expected. Without treatment or engagement in recovery activities, it's progressive, and we've certainly seen lots of those examples in our clinical practices. So if we look at this pattern of behavior, we see impaired control, compulsive use, in spite of and continued use in spite of negative consequences. And in this slide, I've correlated it with the DSM-5 criteria. When we switch to DSM-5, of course, what we see is a very pragmatic approach to a spectrum disorder, from mild, moderate to severe, that looks at the negative consequences that occurs with persistent use. So they really look at significant impairment or distress that's manifested over a period of time, in this case at least 12 months. And they look in the domains of impaired control, social impairment, risky use, or the pharmacological criteria. So a very pragmatic way of breaking down the manifestations of a substance use disorder. So if we think about impaired control, there's 4 different areas in the DSM-5, but it talks about problems in terms of performing a person's role in the workplace, within a relationship, within a family, and so on. Not being present for the work that life expects us to achieve on a day-to-day basis. This is, that's social impairment. I jumped ahead. With regards to impaired control, it's really about that relationship between the person and the substance. So do they have control over their use? It's one thing to go out and enjoy a beverage alcohol, for instance, but the question then is, are they able to shut it down at an appropriate time, or does it spiral out of control thereafter? And is that impaired control evident in terms of not only thinking about it, but getting the money or the resources to put it together in order to get the substance, to use the substance and recover from it? I commented on social impairment already with regards to role failure and the sacrifice of important activities. And then, of course, there's risky use. And JH would be an example of that with a DUI. Risky to themselves, risky to the other members of the public. And then pharmacological criteria in terms of tolerance and withdrawal. And of course, people often think that, well, if there's tolerance and withdrawal, there must be a substance use disorder. And that's not true at all. And we see this quite frequently in terms of palliative care, people on opioids for chronic pain, where there's going to be physiological dependency that develops, which if there's sudden cessation of the use of the medication, there's going to be a withdrawal syndrome. That isn't what we see with a substance use disorder because there isn't the behavioral manifestations of the negative consequences. So 2 or 3 symptoms, mild, 4 to 5, moderate, 6 or more, severe. And certainly in the case of JH, if you ticked off the negative consequences, there would be 6 or more there. It's really not difficult to get to a mild level, quite frankly. So that's pretty dry stuff. That's clinical. That's our diagnostic criteria or definitions. This is perhaps a better way of summarizing it in general. And as a pathological relationship, again, thinking about that relationship between the person and the use, with a mood-altering activity, inclusive of not only substances, but also process addictions, such as I mentioned, gambling, internet porn, sex, and so on, with life-damaging consequences. Bradford's written quite extensively in terms of the recovery and self-help literature, and I think that's a pretty succinct summary of what we see clinically. But what sets people up for this? It doesn't suddenly drop out from the sky, although there are some people that quite interesting will report that with their first drink, in retrospect, they were alcoholic. They saw it on reflection, and I'll comment on that shortly. But these are some of the risk factors in terms of the biology or genes, keeping in mind that genetically that confers the structure of the brain. But what happens in terms of the environment is the connection within those structures. So with regards to the biology and genes, certainly there's been well-described genetic components with regards to alcohol in particular. Increasingly, we're seeing studies with regards to stimulants such as cocaine and crystal meth. Gender certainly has an impact on this because of the difference in metabolism of alcohol, for example, between women and men. Women with decreased alcohol dehydrogenase tend to get a higher level of blood alcohol faster, last longer, and their progression towards end-stage cirrhosis tends to be faster. You layer on the risk of sexual trauma or assault and the psychological sequelae of that, and of course you get a perfect storm sometimes for the continuation of substance use. Also, genetic or otherwise related mental health disorders, quite commonly co-occurring with this construct, if you will, of people perhaps self-medicating to deal with their depression or anxiety or their mood disorder. Layer in environmental challenges, the ACE study, which I'll comment on, that James mentioned as well, the presence of a chaotic home life, particularly in childhood, or abuse, the parents' attitude towards substances, peer influences, which of course have greater credence in the adolescent period, community attitudes with regards to substance use, poor school achievement, all of which may be further risk factors with regards to a person using substances in a binge pattern, where you have a rapid rise in the blood and brain level, interacting with the brain, obviously, and putting them at greater risk of developing a substance use disorder. No one risk factor may be dominant. Often it's a combination of things, but nevertheless, these are commonly seen as the most common routes. Pictorially, one way of framing this, of course, is thinking about the genetics as a fault line in the brain, much geologically similar perhaps to the San Andreas fault, where the genetics and neurobiology are inherited. They're there with stressors that come from the environment, toxic stress in childhood, environmental and developmental challenges depicted here by children in a Romanian orphanage, combined with exposure to substances in that binge pattern, with persistent conditioning, remembering that it's both positive in terms of the higher euphoria, the enjoyment that people experience, as well as negative reinforcement, which occurs when a person is in withdrawal, and then they use, withdrawal goes away, the negative side effects are ameliorated by use, so you have negative reinforcement as well, coming together in a form of perfect storm. I'm going to comment briefly, because James went into this as well, with regards to the Kaiser Permanente adverse childhood experiences study. This goes back to 1998, N of 17,000. This is significant when you're dealing with an N of 17,000. And basically, they just said, is there a relationship, or they asked rather, is there a relationship between adult health status and childhood abuse or family dysfunction? Basic question. So they define these adverse childhood experiences, as you would fairly pragmatically: physical abuse, emotional abuse, sexual abuse, or growing up in a household where there's significant dysfunction in terms of an alcoholic or drug user, someone in and out of prison, someone mentally ill, domestic violence. These are significant levels, not low levels, in the absence of a biological parent. And each of these were given a score. It wasn't the number of events, but just whether or not they had experienced any of these within the category. And of course, what you see here, and in this, for the purposes of this presentation, I focused on substance use, smoking, COPD, alcoholism, IV drug use, increased number of adverse childhood experiences, increased risk of developing these disorders in adulthood, which has implications, of course, in terms of how we look at substance use disorders as a pediatric disease, and also with regards to public policy, with regards to children at risk. So in this slide, what you see is the greater risk that occurs with early exposure to substances, the so-called gateway exposure. Most commonly, this is tobacco, alcohol, and cannabis. And what you see is that with early onset of exposure, there's a greater likelihood, not 100%, but a greater likelihood of a person developing dependency. So there are a couple of things that you can take away from this slide. Number one, when it comes to children and adolescents, delay the onset of exposure. That would be the best advice. So early mentoring isn't necessarily a good idea, although there should be education, but delayed exposure is the best way of approaching this. The other thing that you see here, in spite of the high peak for cannabinoids and alcohol, is the persistence of tobacco. So even delayed onset of exposure to tobacco still has a significant risk of a tobacco use disorder developing. So tobacco is somewhat unique in that sense. And of course, all of this, as you know, relates to the ongoing development of the prefrontal cortex of the brain into the mid-20s. This is a slide that I take a great deal of comfort from because it helps to explain, maybe excuse my own adolescent behavior, which I hope my mother has forgiven me for. But nevertheless, this is an important area of the brain because it is important for consequential thinking about the consequences of one's behavior further down the road. And frequently in adolescence, you know, the weekend is a long way off. 2 weeks is, that's a long period of time, as opposed to people that, as they become more mature and elderly, and in some cultures are highly revered, are thinking consequentially 7 generations down. So before a community will take an action, they'll be thinking about the ripple effect that goes on for more than just their lifetime. But why is this so powerful? Those are the risk factors. That's some of the background information. But with regards to the neuroscience, what we see here is a coalescence of the impact of these substances in the mesolimbic area of the brain, the pleasure area of the brain, the nucleus accumbens, the ventral tegmental area. So there are common pathways that coalesce in the pleasure area of the brain that then reflect forward into that prefrontal cortex. This helps to explain why many people coming in for treatment don't have a single substance use disorder, but it's a combination. Not uncommon in my practice, for instance, for people to use speedballs, a combination of stimulants and opioids of various sorts, or for instance, for people coming in to have problems with alcohol, benzodiazepines, and so on. So it makes it a little bit more complicated because of the behavioral patterns that are attached to particular substance use. The common pathway, not the only one, there's glutamate and other neurotransmitters involved, but the most common one is dopamine. And here we see the role of dopamine in pretty basic functions. These are rat studies where you can see the change from a baseline level of 100 to 150 with exposure of the rat to food. I think if we were to apply this to humans, throw in chocolate in the mix, we might see a significant difference in that. Who knows, it might even reach the level of sex in the slide on the right, where it goes from 100 to 200. Clearly, this is a male rat responding to the female rat being present, no doubt a heterosexual rat. You would have to speculate as to why the guys in the lab didn't want to produce the results with regards to the female response to the male rat being present. But we all know that it's only estrogen that complicates life. Testosterone does not at all. Right. But compare that. Compare tobacco, compare, if we go back, keep that in mind, compare food rather, and compare sex to what we see with exogenous substances. Crystal meth, methamphetamine, going from your basal level of 100 up to 1,000, 1,100, 5 times that of orgasm, to put it into context. Very rapid fall off, however, so the quality of that high, if you will, is going to be different than what you see with another stimulant. Cocaine doesn't go as high, but it's much more prolonged. And then look at opioids in the bottom right. Again, not quite so high, right at the level of sex, however, but prolonged over several hours. You can see how reinforcing this can be. And then nicotine, more than sex. So what's really happening when people step outside and light up? The initial draw is very deep when people will light up when they're in a bit of nicotine withdrawal. Very deep inhaling, several puffs to get that nicotine level up very high, and then it drops off. There's more social interaction and that sort of thing. But again, when you compare nicotine with sex going back, you see that it's at a level that might explain that post-coital cigarette, perhaps to get over the disappointment, or maybe to complete the act. Who really knows? I have no experience with this. I listen to a lot of stories, though. One doesn't know. But again, one also has to think how reinforcing this dopamine surge is going to be for some individuals. When it's going from 100 to 1,100, it explains why people exposed to crystal meth will have about a 10% likelihood of developing a stimulant use disorder, as opposed to that 10% of individuals developing an alcohol use disorder over a lifetime. So with stimulants, first exposure may be enough for 10% of the population. For other substances, it takes more repeated exposures to get to that level where they're running into significant problems. So what happens over time? You get this exogenous stimulation of the pleasure area of the brain, the release of dopamine for one. People get high, they get euphoric. That's specific to the substance, of course. But over time, there's exhaustion of that dopamine system. There's downregulation of it. It's harder and harder to get high. People are chasing the dragon, trying to re-experience that first euphoric event. It's harder to do because of tolerance. They're struggling to feel normal, and then over time, they're simply using to avoid feeling depressed and being down and in withdrawal. So by the time they grace my door, they're sick and tired of being sick and tired. They're worn down by it. Here's another picture, if you will, that shows the impact not only on the dopamine pathways more generally throughout the brain, but also serotonin. So this explains why some of your patients come in and are feeling ragged. They're not sleeping well, which is what they might be complaining about. Cognition is impaired, memory is impaired, mood is certainly depressed by and large. And of course, they may be presenting with symptoms that would reflect a substance use disorder, but they're not acknowledging its presence at all. When we look at PET imaging, you see the healthy control on the left. I'm sorry, it's a little bit blurry, but the dopamine system is showing up as a red-orange on the slide in the healthy control. You see the downregulation in the persistent meth user. So this leads to structural as well as functional changes in the brain. So one way of reframing the neuroscience of addiction is as a brain disease, as a form of slowly acquired as opposed to as an acutely acquired brain injury with disruption in the reward and motivational centers, leading to irrational thought patterns and behavior. So I think that there's more that we can learn from in terms of physiatry or rehab medicine, more that we can learn from with regards to brain rehab that can inform how we treat substance use disorders. So a whole lot of background. Let's talk about our physician population in Saskatchewan and how is it reflected in what we see within the Physician Health Program? This is an example of, or a breakdown rather, of people contacting the SMA Physician Health Program. Some of you may be thinking of SPARC back in the day. The College of Physicians and Surgeons sat on the oversight committee. That has changed profoundly, and I'd like to acknowledge Dennis Kendall's role in stepping back as registrars of the College of Physicians and Surgeons, which opened the door for more self-referral by physicians and learners in the medical community. So the door is open for people to contact if they're struggling with a health problem very broadly. Physicians, 40%. Students, 20%. So people are presenting early, which is good. Residents, 24%. So our learners in the healthcare system are presenting early on and at levels that exceed that of the physician community, even though their numbers are smaller. Spouses of physicians are accessing the service as well as other family members. And then, of course, there are people contacting us for information with regards to how we do that. Those are contacts, people simply phoning in looking for information. Referrals, of course, indicate that there's a higher level of concern. Again, self-referred, over 50% self-referred. This is good. They're coming in ahead of the college, ahead of complaints, ahead of the regional health authority, hospital, or physician group. They might be leveraged, but they're still stepping up and doing it on their own volition. 18% from the College of Physicians and Surgeons or a colleague, 18% in terms of the professional relationships or a colleague, 11% in terms of the regulatory body, the College of Physicians and Surgeons. Sometimes a treating clinician will be making the referral. This is something that's negotiated very carefully, and part of the reason a treating clinician would make the referral is because of the access to services that we have that might be over and above what's available within the healthcare system, and I'll be mentioning that later. And then, of course, referral or leverage in terms of the spouse or family member expressing their concern. When we break it down, in terms of substance use disorders, as you can see, it's a relatively small amount, 16%, compared to 44% that are dealing with an Axis 1 diagnosis under DSM-5. So in terms of mental health, psychiatric disorders, that would be 44%. Occupational challenges, so-called disruptive physicians, or perhaps people that are really struggling with issues within the workplace would be 21%, 13% family relationships, spousal, children. I've mentioned the substance use disorders, and then, of course, aging and the physical, cognitive, and other medical health problems, relatively low but still present. So that's the spectrum of things that we deal with within the Physician Health Program. With regards to substance trends, which is more germane to the topic here, what we're seeing is more opioid use, both IV and oral, amongst younger and more male than female physicians, particularly in anesthesia. Occupational hazard, you might suggest, in that cohort. With regards to females, however, particularly in a younger demographic, we're seeing more commonly alcohol use. But alcohol use and problems with alcohol use increases with age if there's persistence. Marijuana is becoming more of a presenting issue with students and children of physicians. Benzodiazepine abuse is often there, but it's a little harder to detect. Also, what we're seeing are trends that are supportive in the sense that people are coming in younger. We saw that in terms of contacts. This is good. They're coming in before the substance use disorder has become more severe and is more difficult to treat and put into remission. So self-referral, younger people are being more proactive. Part of this, I think, relates to the importance that's being placed on wellness and work-life balance, a sense of harmony in the transition into the profession early on. Process addictions are less common, but they're certainly there, particularly with regards to gaming, internet porn. We're seeing this more amongst the learners. Gambling and internet pornography, perhaps more amongst practicing physicians. Isolation in rural communities might be an issue with regards to this. or people that haven't been able to establish a primary relationship, in part because of the demands of the profession as they get older. Also, with regards to trends, we see patterns with regards to concurrent mental health and substance use disorders. So depression, anxiety, OCD, ADD, bipolar, certainly the most common Axis 1 diagnoses. Advancing age in our province does pose its challenges. What we really have challenges with, however, from a treatment point of view, are the Axis 2 disorders. These are more personality. And of course, when it comes to treatment of someone with a straightforward mental health or psychiatric diagnosis, good clinical care pathways, what's expected, though, within the profession is a higher level of performance that expects more in terms of the personality of individuals than what you would see in the norm. So although someone may generally present in a normal way with regards to the personality, their interactions as a professional are expected to be at a much higher level. And this is sometimes where people run into difficulty, where they just can't quite hold it together when there's conflict, when there's stress, when there's complicated issues that need to be addressed in terms of both patients and the healthcare system and their colleagues and so on. Finally, what we see is that sort of existential angst, certainly amongst learners. Is this the profession that I want? Am I where I want to be? Am I in the specialty that I want to be in? It's hard to change sometimes when you've been matched, and sometimes people are beginning to feel that it's a sentence rather than a career that they want to commit their life to. So helping people to work through that, looking at options and so on, would certainly be part of the work that's done in the Physician Health Program. So how do we do this? Let's go back to JH. So she was interviewed and determined to have a severe alcohol use disorder. Her spouse was interviewed separately to get collateral information. She was offered a voluntary removal from practice, prompt referral to treatment with supportive reintegration and monitoring upon her return. So there's a way in and there's a way out. There's a way to help people to transition through treatment, to deal with the stigma, and to look forward with hopefully some hope and optimism with regards to getting their life back. And that's very important because they need to be giving up a substance that they're clinging to rather desperately on one hand and try to resurrect a life on the other, keeping in mind that amongst physicians, the last thing to go tends to be their work. Families get sacrificed, relationships get sacrificed, other things that are important get sacrificed before they're giving up on their work. They're coming in every morning, they might be under the influence, but they're presenting for duty. But so in a situation like this, when it's both a carrot and a stick, clearly there's leverage in behind here in terms of the consequences that are going to be discussed with this individual. Quite frankly, they're on the table, but we're offering a path through all of that. So here the individual, if you want to look at this process map, may be referred by someone else or self-referred. They come in contact with the PHP. They may simply be getting information, some consultation, maybe a referral to a virtual EAP, if you will. There are other people out there that can provide services. We may not need to open a file and monitor and engage in that. They simply need to know who's good in this particular area that I need help in. Contacts made, they're provided that assistance. However, if it's more severe, a file may be opened as part of that initial interview process. If they're receptive to the treatment plan, engaged, there's support, there may be monitoring as they get back into the workplace. However, they may not be receptive. If there's no patient safety concerns, there's an offer of assistance, and then we step back. The law of natural consequences will bring them forward, or they might choose to follow other options in terms of accessing care. However, if there's any patient safety concerns whatsoever, we have a professional and ethical obligation to let them know that if they leave, which is their prerogative, we will have to be contacting the College of Physicians and Surgeons and reporting this because of the level of impairment and the risk to people in the community that they serve. It may sound coercive, but we're just being quite frank and honest in terms of how these things will play out. So in terms of the intervention, there's the assessment, and typically there may be someone who has experience with a substance use disorder or addictions in conjunction with a psychiatrist. There may be reporting back to the referring agent, College of Physicians and Surgeons, College of Medicine, Regional Health Authority, but that's very succinct. Person made contact, they're going to be engaged in care or whatever the case may be. We only report back the bare bones of recommendations that have an impact in terms of the workplace. We typically refer to Edgewood and Nanaimo, BC. We're very fortunate because we've negotiated support from the Ministry of Health, and the Ministry of Health will pay for treatment for physicians out of province. This is worth tens of thousands of dollars, but it's recognized that we're not able to provide this level of treatment within the province. They typically go for 7 to 8 weeks, and there's an aftercare program that's offered by Nanaimo, by Edgewood rather, that's extremely helpful. So there's that voluntary stepping down from practice, so it doesn't come up on their record as being forced to resign. Nevertheless, there are conditions in terms of reintegration. So what works here? Well, there's mandated detox and treatment supported by the licensing authority, and I think that we have to acknowledge that we have a very unique and constructive relationship with the College of Physicians and Surgeons of Saskatchewan and the SMA in this area, where it's seen as a health problem, it's supported as a health problem. If the individual is compliant with the conditions, and that's confirmed when they renew their license, and we confirm it that they are consistent with their undertakings, that's it. There doesn't need to be further involvement. However, the understanding is that if a person is no longer compliant, then there's reporting and the natural consequences that would come from that to keep everyone safe and to keep it transparent and accountable. Aftercare is also important because remember, we're dealing with a chronic disease. All too often in our healthcare system, substance use disorder, a chronic disease, is treated with episodic acute care. Bit of detox over here, 7 to 10 days, then maybe 28 days of rehab over here, and that's it. Maybe not much linkage, maybe not much aftercare. Think of anyone else that you treat in your practice that has a chronic disease. How effective would that impact be in terms of the behavioral and other change and self-management that's required? Not at all. We need to rethink how we do this. So weekly online facilitated peer group discussions are done through Skype or whatever the case may be. Regular PHP contact. They may engage in 12-step meetings, often with other healthcare providers, but not universally so. Personal counseling. Family support is indicated or desired. A contracted return to work. It's often incremental in terms of the re-engagement in the workplace. Some individuals with more than one relapse episode may have permanent conditions. If it's a more severe use disorder and they're actually able to retain their license, they may be on monitoring for life in order to keep them safe and to ensure the public is safe as well. We identify people in the workplace that can provide that mentoring and monitoring, keeping in mind that this is sometimes to the advantage of the individual. And this point also includes the random body fluid monitoring, because they may become a scapegoat or a target in the workplace. If there's a problem, well, it must be that person. Whereas if you have someone who's providing that monitoring, if we have the access to random urine drug screens, people can say, you know, folks, you need to look in the mirror. My urine drug screens are fine. The problem isn't me. It's bigger than that. So there's a way of pushing back and dealing with some of the toxic dynamics that can sometimes occur interprofessionally. There's reporting back, as I mentioned, to the referring agent. It doesn't have confidential information. Rather, this is about recommendations in order to have this person constructively reintegrate. And this goes on for 3 to 5 years. This is chronic disease management. Think cancer remission 5 years out. It's not so very different. So what does a chronic disease management approach look like? Is remission achievable? Fortunately, we have data on this. This isn't just me. But when you look at the outcome studies for physicians in North America, and this is one that Brewster published in the BMAJ back in 08, in terms of 5-year outcomes within physician health programs, 71% of the physicians had not relapsed. 71% were in remission with no relapse. Think of that, and think of the stigma, and think of how we typically frame substance use disorders in people that struggle with it. This is unique. 40 to 50% of the general population relapse in less than 6 months. Part of this is because we don't provide them with the care that we should. We're not using the tools that we have at hand. In addition, in terms of the physician cohort, 14% who had relapsed successfully completed their program in reintegration. So we're therefore up to 85% in remission with 1 episode of relapse. When we look at the 15% that were unsuccessful, frequently there were complex concurrent mental health and access to challenges there that made it difficult to get them through treatment and consistently congruent with their undertakings. Although medication isn't common when we're dealing with substance use disorders amongst physicians, occasionally we do use it. Naltrexone and acamprosate, number needed to treat 9. This is something that we should be using at a primary care level regularly when it comes to treating alcohol use disorders. We're just not seeing the uptake that we should. You're more familiar, I'm sure, with methadone, buprenorphine, or Suboxone, and naltrexone for opioid use disorders, and of course, varenicline, bupropion, nicotine replacement therapy for tobacco. We need to normalize this for all substances in a way that's much more effective at a primary care level. We can use these for physicians as well, but generally, in terms of opioid use, there aren't many that need Suboxone or methadone. It's all been behavioral management. So, what happened to JH? Well, she successfully completed a residential program, including a family program for her spouse and older children. She returned, signed a 5-year monitoring contract, and was able to continue and to engage in care and support. She participated in the aftercare peer group, family and personal counseling, found a supportive AA group. This was all female in this particular case. Maintained PHP contact and rebalanced her life, dealt with some core trauma issues. And her surgical group was very supportive with her return to practice. They were very pleased with the change in her performance and her ability to perform her duties. So not only do we see remission behaviorally, but here on the PET scan, you can see what happens with the return of that dopamine function in the mesolimbic system. We have a brain that's returning to normal. The transition from the person in the middle who's actively using with downregulation of the dopamine system, that individual is very irritable, they're angry, they're difficult to stabilize. That transition back to a more normal functioning brain is what we call post-acute withdrawal. Detox removes the substance from the body physiologically, but the brain has to start to go back to normal. That takes weeks or months. So post-acute withdrawal is a high-risk time for relapse. Support is really important. It takes time for the brain to heal. We all know that. We need to support people in that transition in order to accomplish these changes that we see on the scan in 14 months. So hopefully, as we wrap up, you appreciate some of the fundamentals of substance use disorders and the implications for treatment or care, how it's managed within the Physician Health Program of the Saskatchewan Medical Association, and reflected perhaps and maybe can take back to your practice or home communities things that we can do to improve the treatment and care for people that struggle with this more generally. Resources are available online in terms of ASAM, CSAM, the Canadian Centre on Substance Abuse, alcohol screening and brief intervention through the College of Family Physicians of Canada, NIDA. CAMH has a good toolkit for addiction medicine under Portico Network, AA, and so on. Also, with regards to the medical community more specifically, you might find In the Realm of Hungry Ghosts by Gabriel Maté a particularly good read. Medical marriage by the Sotils is recommended. And if you want to follow up more specifically with the Physician Health Program of the SMA, contact Brenda Sanger. She's the manager. And with that, I'll close. Thank you very much. And hopefully we'll have one question?
5 minutes.
5 minutes for questions. Okay. Dennis, thank you very much for your support.
Peter, I just want to commend you for the amazing leadership you've given for so long in this area. And I do think we've moved an incredibly long way in transitioning treating substance use disorders from some sort of moral failing to understanding the disease model with amazingly positive outcomes.
Absolutely.
And I'm so impressed with the, the increased capacity for self-referral, and particularly among students and residents. But I suspect that much of the self-referral among students and residents is not so much around substance abuse disorders as Axis 1 and Axis 2 disorders, probably.
More of them are, it's more about transitional adjustment.
Yeah.
And,
Yeah.
a few cases of counseling, and they're good to go. They're bright, they're motivated, they're just making some adjustment.
So what I want to touch on, though, is that if you look at the reported incidence of Axis 1 disorders among physicians, either we're remarkably immune from this, or we are in strong denial, and we frankly do everything to cover up the fact that we suffer depression, because it's so hard for physicians to actually acknowledge that we are at the same risks of depression. And so how do we remove the stigmatization that we achieve in that domain, what we've achieved in substance abuse disorders? And then the question I have is most focal around suicide risk. And you look at the suicide incidence, particularly among physicians in training, and it is shocking. And so we still have a long way to go with dealing with resiliency. And I do think that the term burnout is used so widely, it's almost lost its meaning. But the surveys done by the CMA and other agencies suggest that 50% of our profession is feeling burned out. What does that mean to you in terms of physician health, and how do we tackle that?
Well, you've touched on a number of issues, and stigma is certainly one. And I think as we do more in terms of reducing stigma broadly within the community with regards to mental health conditions, hopefully it'll percolate down to the profession and we'll actually internalize that this is a health condition, just like anything else. There's no shame in having hypertension. We have ways of treating it. We have good biomedical models of care. We simply need to encourage people to step up and say, yeah, I think I need to fine-tune this and get some help. I think part of this, too, is some of the work that's being done through the Residents Association is particularly good, because they've gone to the military, and the Canadian military has adopted and adapted a program that was developed by the Marines in the United States, which it's about the road to mental health, and it categorizes, whether or not a person is well, whether or not they're reacting, whether or not they're struggling or in fact ill. And it creates a structure where it encourages the conversation between buddies. Just as you have comrades in arms, so also we are comrades within the profession. And it encourages people to be able to give appropriate feedback when they see a colleague is in difficulty, so that they can get the help that they need. And part of this is not to undermine our commitment to high-level performance, but rather to use that commitment to get care early on so that we stay functioning at a high level. So, mental health, just like training for any other marathon and that sort of thing, needs to be supported and sustained over time with rest, relaxation, other activities, so we can do the demanding work that we do and sustain it over a longer period of time. I think that, you know, the role that you and the College of Physicians and Surgeons have played here, as I mentioned, has been an important one in stepping back so that people don't feel that there's a regulatory threat in terms of coming forward. And I think the way that the college handles how we manage our health within the profession is good. I understand that there's some dynamic tension there with regards to when does a health condition pose the risk of harm to a patient. That's being worked through at a regulatory level, and it's an interesting and very nuanced conversation. What is the level of risk? We can't pretend that it's zero, but on the other hand, I think that if people are being responsible and looking after themselves, the regulatory body should back off. But that gets played out a little bit differently from jurisdiction to jurisdiction. So certainly, ironically, dealing with stigma within the professional community is one of the issues that we need to deal with. And what the learners are doing, the students and the residents, in terms of pushing a wellness curriculum and that sort of thing, which is now an accreditation standard, is important in this generational shift that we're seeing. Yes, sir.
Yeah, I wanted to make a few comments. As a psychiatrist with 35 years experience, not particularly focused with addictions, but I think they all deserve a trial of insight psychotherapy, individual or group, short-term, long-term. It sometimes takes several years actually to repair the defects in the self due to the childhood traumas. And just made a short list of the kind of work that one gets into over months and years. Repairing defects in their self-image and their self-esteem, improving their ego strengths. They often have impaired, immature ego defenses. There are usually problems with guilt and shame. Perfectionism is common. They need to make readjustments in their expectations of performance. There are always grief issues, PTSD, unresolved, unexpressed. Access to character issues are very common with addicts. Narcissism, OCD, and perfectionism. Looking at some dream work, trying to get at archetypal conflicts and issues in the unconscious is important. Improving communication skills. Also, just a general look at philosophy of life and values and ethics and so on. I've always found this work very exciting and challenging. Of course, there are a lot of resistances that people have, and part of the work is interpreting those. They're often related to childhood defenses that are no longer appropriate.
I think you're absolutely right in terms of some of that work, that very personal, that intimate work that needs to be done. In the time that it takes, 1 to 2 years isn't at all uncommon. And when you think of how essentially what we're doing in terms of substance use disorders is helping people put together a life worth living without using. It gets to the core of their being, and that line of inquiry that you've described is important, which is also why when one is engaged in this work, one sees transformational change over time from people that are really struggling. Part of that is reflected in their use, of course, but the person that they become and the person that they can become is sometimes unrecognizable from the person that walks in. But it takes effort, it takes work, and it's quite profound.
Yes, I would agree with those comments, yeah.
Thank you very much.
Thank you.